very, very much, Dr. James. I think it has been very insightful what you have shared. I particularly got interested in a number of things that you have said, and you mentioned something about the COVID year. It's really an issue I've had from my particular perspective, but it's been pretty interesting. I just wanted to inquire from you, Doctor, because we see even from here in Kampala, one of the biggest issues around COVID-19 is there's so many myths around it, you know. So everyone kind of seems to have a myth around COVID-19. And I just wanted to inquire from your perspective, from the rural perspective or from the rural health perspective, what were some of the key myths that you maybe had around COVID-19, and how did you as a Kiwoko Hospital fight these myths or combat them?
Thank you, moderator. Myths are quite many. The very first one that I ever heard was that this disease cannot affect Africans. And so it created a sense of safety, people feeling, oh, we are untouchable, we are okay. And then at some point, people continue to think they have a strong immunity. It's only for the elderly and those that are frail. Of course, we know they are affected worse than the much healthier younger people. And also people thinking that the young people don't get it, or if they do, they will not suffer as bad, which is another myth that people have had. So generally speaking, even in the rural area, not very different from the town, there's a laxity of people wanting to adopt the preventive measures. They have all sorts of reasons. I've heard people complaining about breathlessness, and you know, anyone with anything on their face will feel a bit uncomfortable. However, the discomfort from the mask wearing can be mitigated, and you get used to it, and that should save you from a worse happening if you got COVID. So in our own community, mask wearing is also a very big challenge. In fact, people think that when you wear a mask, you are the one that has the disease, and you'll be stigmatized thinking you actually want to spread it, so keep away from us. I remember one of our staff that went to one of the markets and was denied access because he was wearing a mask, and he was told, you have COVID, please do not come in here.
So in that situation, how then do you handle it?
So we encourage and continue to ensure that all our staff are showing a good example. We encourage them to wear their masks even in the community. When you come in a rural area, you may nearly tell who is a hospital worker from Kiwoko by seeing someone wearing a mask. The chance that the person you see wearing a mask in our rural area, that they are a staff of our hospital, is very, very high. And we encourage our staff to be leading and talking to people. We do educate those who come both in our unit as well as those who do not come in, but we have VHT teams and our community arm of healthcare provision does teach people on COVID, and we try to help the community to understand their need and role in the prevention of the spread of this disease. Some actually also learn from what they see. For example, when they see ambulances coming in and picking patients to take to another health unit, we take time to tell them, look, that is what it is, and it is here. So don't think it is not here. Do what it takes to make sure that everybody is safe. And we also support them when they have discomfort from the way of mask, like we talked about the COVID year. There are tricks that you could play to try and see how those loops don't cause pain behind your ears. And one of them could simply be making a knot on the loop of the mask, or even putting a rubber band at the back of your head that holds the loops, and that should be very helpful. And we have seen different designs of masks. There are those that are made that do not have loops that go around the ear. So all those have been very helpful in trying to help people to comply with the guidelines with the prevention of the COVID spread. Thank you.
Okay, thank you. I think it has really been powerful what you have said, and it's not lost on us from what we've been discussing that it has been really an uphill challenge. But from the discussion we're having here, we feel that you're actually managing it quite well, and we're actually really proud and happy of the kind of work that you are doing. And maybe just to continue with this, we've been speaking about Adara Group for a bit. Dr. Peter had mentioned Adara Group. And right now at this juncture, I really want to introduce Miss Hilda Namakula, who's going to talk about the COVID-19 and how it has had its impact, especially from the neonatal side of things. So, Miss Hilda, we are ready for you. Please note, ladies and gentlemen, all the speakers, that we're going to have a time cap in this conversation. Let's make sure we can have this within about 5 minutes for the remaining presenters, so that we have enough time to, you know, catch up with questions and then conclude within the agreed upon time. Okay, Ms. Hilda, the floor is yours.
Thank you so much, the moderator. Allow me put off my mask. Good morning to you all participants, and thank you everyone for organizing this webinar. My name is Namakula Hilda. I am a nurse by profession. Worked with Kiwoko for 9 years in the neonatal intensive care unit and currently working with Adara Development Uganda. I'd like to share my screen. Okay. Who is Adara? First of all, Adara Development has worked with Kiwoko in partnership for about 20 years now. Adara is helping in improving maternal and child health in Kiwoko Hospital. And Adara believes that each and every person should have access to quality health and other essential services, no matter where they live. So that is why they have decided to come in and make sure that the people in the rural area can also access these services regardless of where they live. Adara has also worked with Kiwoko across community-based healthcare, support to clients with HIV/AIDS, and support to at-risk mothers and babies since 1998, as Dr. Peter has shared with us. So, briefly about the hospital NICU. It was started in 2000, and as the first NICU, it opened its doors after months of building, staff training, and extensive work to source equipment. Because without equipment, you cannot run a neonatal intensive care unit. Protocols were established, and after all this, it was a triumph. Though relatively small, the Adara and Kiwoko teams knew it had the potential to save many lives. So after that, after years of continuous improvement, the opening of a bigger and better NICU in 2010 took place together with a state-of-the-art maternity unit, and the Kiwoko is now one of the leading units in Uganda, and we are so proud of that. So in the 9 years following the building of the new NICU, admissions rose by 169% to more than 1,300 babies per year. Despite this rapid growth, NICU survival rates remained around 90% over the period. Now this gives us a joy. Kiwoko neonatal NICU is one of the best in the country. Staff from other facilities across the country travel to Kiwoko to learn from our NICU, and this has helped them to establish their neonatal intensive care units. Now, we've had staff from Busia, we've had staff from the northern Uganda, and they have come to learn from us, and this has led to establishment of NICUs in their areas. Statistics of NICU admissions. There have been 10,569 admissions to the unit since 2009. There were 1,192 NICU admissions in 2020. This is a 9% decrease from the 1,311 admissions in 2019. We shall see the reason as to why this decrease has come up Admissions have increased by 169% since the new NICU opened in 2010 with an annual average growth rate of 7%. Now, this table displays how the admissions have been in the year 2020. Briefly about maternity, I'm so grateful that Dr. Peter has talked about it. Also, the admissions reduced in 2020. In 2020, there were 3,436 admissions, and as compared to 2019, we had 4,010 admissions. Now, this reflects a decrease in percentage of 14% in the admissions as compared to the past 3 years. The table below reflects how the admissions were in 2020. Now, as the NICU, we have a 90% survival rate, but we have challenges. One of the challenges we have is limited space due to the prolonged stay of the preterm babies. Now, our NICU mostly admits babies who are preterm, those who have low birth weight, having a weight less than 2.5. And these babies tend to stay for quite a long period of time before they are discharged home, and this takes away the space. There is need for an assimilation laboratory for training, since health workers are coming for training and benchmarking at Kiwoko Hospital NICU. The Kiwoko Hospital NICU is busy. It is having so many admissions, but the other health workers from other facilities have always come to learn from us, and we think we need an assimilation laboratory for these trainings to be effective, which is not existing currently. NICU lacks sufficient training space for mothers, especially during health education. Our mothers are trained right away from admission, and the trainings are ongoing till discharge. So we are lacking a sufficient training space for them, since we are in the COVID era where we need social distancing. So what has been the impact of COVID-19 on the Kiwoko NICU? Some activities were put on hold. For example, the follow-up visits, because of the lockdown and the potential to spread COVID-19 among the communities. Mothers were not able to come back for follow-up visits. Low client turn-up in the follow-up clinics due to lockdown restrictions, especially on transport, increased transport costs, fear of COVID infections, and then curfew. Clients couldn't turn up. There were also restrictions on the process of coming to the health facilities. Staff training and continuing medical education was also put on hold due to COVID-19 measures like avoiding gatherings. So we couldn't gather because we needed to follow the COVID restrictions. Unplanned costs in terms of purchasing PPEs like masks, face shields, aprons, and installation of more hand washing facilities in the unit for staff safety during patient care. So it had constraints on the budget. It also came with increased workload for departmental staff due to an increased need to teach mothers about COVID-19, as well as taking care of babies. It required time to teach the mothers as well as attending to the babies. As a result of COVID-19, new mothers' accommodation was created to avoid infection and allow social distancing. New guidelines about COVID-19 prevention in the unit were put in place. For example, routine COVID-19 screening of every mother and staff per shift, wearing of masks by all mothers and staff, as shared by Dr. James. Now in Kiwoko, still working in partnership with Adara, we have a program called Hospital to Home. Now this is the community arm of the Kiwoko Hospital NICU. This program was launched in March 2019 as a research study, though results are not yet published. This program was designed to give newborns the best start to life. It ensures that infants receive follow-up support after discharge from the NICU. When they're discharged from the NICU, they are supposed to be followed up even in the community because they are vulnerable. More newborns in low-resource settings are surviving due to increased access to advanced newborn care. However, infants who are born small or sick are at a higher risk of complications after discharge from the hospital. This is why the hospital-to-home program came in. So our H2H program provides vigilant in-home follow-up support, helping these babies not just to survive, but also to thrive. So this program has two components. One of the components is the hospital component. Now the hospital component involves packages like lactation and breastfeeding. With lactation, since we receive most of our babies as preterms, we are supposed to help mothers practice expression of breast milk using their hands. And this helps in the feeding of these babies since they are not able to breastfeed. And when they start learning how to breastfeed, we are supposed we help these mothers to support them during breastfeeding, to help them with attachment, to help them with positioning during feeding of their babies. It also has a package of neurodevelopmental and supportive care. This package comes with kangaroo mother care. Now, kangaroo mother care is a practice that promotes thermoregulation amongst these preterm babies since they are not able to keep themselves warm. It also involves cue-based feeding practices, which practices are based on babies' behaviors and their individual and their safe practices. So we incorporate cue-based feeding in our H2H program. We also incorporate feeding education and support. This is now to the mothers because they have to learn how to feed these babies and support them even when they go back home. Regulation of environmental stimuli for positive outcome. We regulate the environment, we reduce noise, we regulate pump alarms, we regulate oximeter alarms, so that to promote brain development in these preterm babies. The hospital component also comprises of the discharge planning package. Now, this discharge planning package begins on admission, and it involves individualized care plans because each patient is unique. They have different problems, so their discharge care packages are individualized. It also involves a team approach to work towards discharge. Now, this involves the nurses who work as discharge coordinators. It also involves the neonatal therapists and the doctors in the ward, so it is teamwork. It also involves education and empowerment of families. Even on discharge, mothers are educated and given empowerment as they go home in support and care of these babies. So, the second component of this hospital-to-home program is the home component. So with the home component, we work with a network of 100 Adara trained village health team members supervised by a community midwife. These VHTs provide ongoing care to families at home for the first 6 months following discharge. They also provide support to newborns and mothers and refer patients when additional care is needed. By following up these babies, we can identify issues and intervene early. This gives this infant the opportunity to reach their full potential, because if there are issues, they are identified early, they are referred back to hospital, the hospital reviews them, and then when further referral is needed for specialized care, they are sent so that they can access care from specialized health facilities. In 2020, we had 94% of eligible babies who received follow-up from the hospital-to-home VHTs which is an amazing thing considering. So what has been the impact of COVID-19 on the hospital to home program? Follow-up of babies by the VHTs in the community was halted due to lockdown. Now we had to resort to phones so as to get the information about these babies, to see how they are doing, to find out from mothers how these babies are doing. There's increased anxiety and fear amongst the VHTs and mothers, especially during the visitation of babies. There's increased transport costs, which hindered mothers to access health services when babies needed them. It also caused the constraints on the budget in order to purchase masks for H2H mothers, to purchase COVID-19 incentives like soap, masks, hand sanitizers for the VHTs for safety. VHT monthly meetings and support supervision were put on hold due to lockdown. It couldn't take place because there was lockdown. Increased poverty amongst the H2H families due to loss of jobs, secondary to lockdown. Now, most of our H2H family heads lost their jobs because of the lockdown. Most of them are border riders, and this increased the poverty amongst them. Increased hand washing practices in the H2H families due to the COVID-19 measures. Now, VHTs had to teach mothers, even on phone, they had to teach mothers about COVID, how to do hand washing. And when the lockdown was relieved, we found out that there was increased hand washing practices among our H2H families. Thank you so much for listening.
Okay, Hilda, I think it's very powerful what Adara is doing in partnership with Kiwoko Hospital, because I believe it says a lot for a partnership to go for over 10 years, and this particular one has been there for 20 years. And from the things you've been talking about, I noticed that it's really dawned on me that Kiwoko is very impact-based. It's an impact-based kind of hospital. Because if you talk about programs like the hospital to home, it's been very insightful in regards to understanding how you're going beyond just the call of just treating a person or making sure that the babies are born, but you're taking it even further to go and actually see and ensure that the child actually goes beyond just the particular, treatment that they get from the hospital. This is very commendable. I noticed also that when you were talking about the impact of COVID-19, you talked about resorting now to using phones in how you're going, in communication and in reaching out to people. And this is bringing me really to the next speaker, because what we have learned from COVID-19 is that it has forced us to start to innovate new ways in which we can go forward. And there's a company there are a number of different organizations which have come up to create solutions for this. And there are a lot of medical technologies which are coming out to help people, even do better. So one of these is a company called Meditech, or Medic Mobile actually. And we have a gentleman called Mr. Brian Ssennoga, who is a partnership specialist for the African region for Medic Mobile. Brian is going to really be telling us about some of the solutions that they have helped or that they have created in this period for the medical sector that could help a hospital like Kiwoko be more effective in actually handling the patients they have or in handling the cases that they're getting. So, Brian, you're very welcome. The floor is yours. Please just be mindful of the time constraint. We have basically about 28 minutes to conclude this. So, Brian, I'd be very grateful if you could use 5 minutes really tops to just walk us through what Medic Mobile is doing, and we can start to have this conversation and see how best we can work together with Kiwoko Hospital to deliver or to provide services to help them get to where they need to get to. Okay, Brian.
Thanks, Ronnie. Thank you for the session so far, and great to be here. I hope you can all hear me clearly. I'll just make sure that's loud enough.
Yes, yes, I can.
So, yes, I'm truly excited to talk about technology, and I think my passion, especially with being friends with the people at Kiwoko, we've had some conversations initially about the role of tech, and I'm happy to come here and talk to us about the specifics around COVID-19 and how a community hospital like Kiwoko can take advantage of what we're talking about. When you think about COVID-19 and you think about what Kiwoko Hospital is doing, then you cross over and you try and marry that with what the rest of us in technology do. There's maybe three to five phases that we have looked at in the technology world that we've considered that are important to understanding how the COVID response can be managed by facilities, especially community-based facilities. So in the early state of the pandemic, we were really talking about the question of detection and whether we could be able to prepare well enough as a country, as a community, as a hospital. How ready were we in terms of the preparation to handle this pandemic? And then there was that phase when we had initial lockdown, and at that point we were talking about early detection signs and what we were doing. And then we spent most of 2020 fighting with containment, whether that's keeping the borders closed, keeping the curfew hours and all of that. And then of course, control and mitigation. So how do we make sure of what we have, we're actually not going out of hand? And now, last night I was listening to the news, and we're talking about orders for the government, ordering vaccines. And so this is pretty much how we think about the COVID response. And so as I work my way to share with you a deck so that you can sort of begin to see and we can map this out together, the role of a place like Kiwoko Hospital and its technology partners, and how together we support what we're trying to achieve. So the role of technology in supporting a place like Kiwoko to deal with this response at the community level, for me, fits in these four main buckets. And this is how Medic Mobile's response using technology has been driven. We really want to prioritize the health and safety of the community health workers, because if they are safe, they continue to provide much needed care. And in the context of community, we're talking about doorstep care, and that's very important. And their safety and the role of community health workers being protected includes services like projecting personal protective equipment, health workers themselves conducting their own health checks and being able to report those to their supervisors so that the supervisors know that you still have a healthy workforce to support. We can't meet physically, and it's true for health workers as well. So how could we make sure that community health workers can onboard remotely? They can link up to what they need to do without being in the place. And that extends to capacity building and training and even mental and health support. Kiwoko still has to then go on to bucket 2, which is the surveillance and detection component. This is the place where we truly rely on the healthcare system to help us see how are we screening, detecting, and surveilling and tracing the incidence of COVID in the community. It's a big deal now. We're making some really, really tough decisions. Kids going back to school. And we just come out of elections, and there was all these restrictions as a result of COVID, but elections by their nature are a public thing. And so we probably have a huge instance of COVID to deal with. How do we contact trace everyone who is possibly exposed? How do we make sure our healthcare providers like Kiwoko have the tools they need to support this process? And when those patients are traced and found and they come into the healthcare, then we go to the next tier, which is symptom screening, rapid diagnostic testing, referrals and closed loop referrals, and then of course messaging. How do you message people in quarantine at home so you remain in contact with them enough to remain plugged into their status and their healthcare situation? And then bucket number 4 is, what then do you do with what was routine or normal healthcare? So there was stuff that community healthcare workers at Kiwoko were doing before COVID. And so we talk about adaptations to healthcare workflows. Can a community health worker just go and conduct a routine assessment the way they used to before COVID? No. And if that has changed, how have we adapted not just the care workflow, but the process, the policies, the frameworks, the guidelines that support this? So when you sort of look at the life of the pandemic, these are the areas where you really, really want to intervene. We're now approaching 12 months living with COVID, and we're now discussing eradication. But can you say we have done a good job at detection? Can you say we have our points, our border entry points, figuring out where Kiwoko sits right on the highway and is now a major referral center for trauma and all this? It means you're doing a lot of event-based surveillance, you're doing a lot of contact tracing. You need people to participatorily or voluntarily give you information. And so you need technology that adapts to this reality. This is how a place like Kiwoko wants to effectively deal with COVID-19 and become truly a center of excellence. I'm also interested in the fact that Kiwoko, in this case, has a school. And so this isn't just the reality of what we're doing with COVID now, it's also very much setting the stage for how we're training the next group of healthcare workers and what we think their training needs to look like so they prepare. And this might feel like on-job training, like we really got into the deep end pretty early. But that's good, because now we can use this to truly set the standards, the frameworks, the learning opportunities that are important for our healthcare workers, the ones that are coming up through schools like Kiwoko's, to know exactly what to do and how to handle situations like this. The lessons we're going to learn about COVID, by the way, especially in the community, are applicable to any other outbreaks. So imagine that the effort that we're putting into COVID, we were putting into measles for children. Imagine that we were putting into malaria, childhood and pregnancy malaria. Imagine that we were putting this into TB and HIV. Imagine that all of these outbreaks had the same concerted effort in programmatic design as well as in technological and process intervention. This is what we want to change. And so the technology partners that are going to support hospitals and care providers like Kiwoko are not just going to be people coming with great technology. We're going to come alongside you because we truly understand the environment in which you're working and what you're trying to achieve. And hopefully, this is an example of how technology that truly wraps around the problem and is designed to support the intervention can be used in a situation like we have now. And I'll be happy to share these slides later on, but again, this is some of those interventions that we're talking about: remote boarding, training, health checks, even on a daily, and all this work very well on a mobile app, mental health and checking, point of entry to support surveillance and detection and contact tracing. And I'm glad to share that all this has been done and is available for Kiwoko to uptake. So hopefully our conversation today will lead to partners seeing the realities and the benefit and the opportunities that are available, and for Kiwoko to continue to speak confidently about making the leap to digital interventions supporting the work that you have done over the last 30 years being in the community. So I want to stop here and come back to you, Ben, and Ronnie for the moderation. I hope that that was a good start to the conversation around digital intervention.
Thank you very much, Brian. It's been really very insightful, because it's been amazing the things that you have come up with, especially now that COVID-19, came out of the blue. Seeing the kind of innovations that you have come up with, for instance, contact tracing, it's really been amazing, and we're excited to see how it's being used and how the community at Kiwoko is actually, benefiting from this. I'm very excited to actually share these presentations. And for all the presentations that the different moderators have had, we're going to ensure that we share them. We'll send an email after this to everyone who's been on call. If you haven't shared your email with us, you can just drop it in the chat, and we'll be able to also send you these presentations, so we can then further this conversation to take it, a notch further. Now, talking about technology and the medical field, something which has been really key. There are a few other entities which have really been working to just improve and actually boost using technology to help the medical field. And a new term which I learned most about a year ago was telemedicine. And I was just trying to understand telemedicine in the perspective of Africa and Uganda, and wondering whether it would actually work. And in doing a bit of research here and there, I noticed that there's a company that's working in Uganda that's actually called the Medical Concierge Group. And one of the key things they're doing is telemedicine. We have Dr. Pamela, who's on call with us as well, from the Medical Concierge Group, who's going to talk to us about how telemedicine is working in this country and how it has also been impacted by COVID-19. So, Dr. Pamela, the floor is yours. We're excited to hear from you. More about
thank you so much. Thank you so much, Ronnie. I'm going to talk about what we did when the COVID hit. I work for the Medical Concierge as a doctor, and what we basically do is offer telemedicine services in addition to other conventional services. And this includes us giving remote teleconsultations, having a mobile laboratory and pharmacy services available to our clients, and also remote immunization as well, and also follow-ups from the doctors. And what happened is, when COVID came, prior to COVID, we had patients, but not as many, using the telehealth bit of our company. They liked the conventional way of administration of the health services, coming into the facilities, having a doctor physically see you. But because of COVID, because of the restrictions, people are not able to move. People didn't have access to health facilities because of the transportation costs and the limitations, as my other colleagues have talked about. So they embraced the telemedicine aspect, and more patients were using it, calling in, having consultations over the phone with our doctors. We have a 24-hour 24-hour, 7-day-a-week call center that's manned by doctors throughout, and patients would call in throughout the days. Patients would schedule immunizations. We noticed that a few children actually missed immunization during the beginning of the pandemic, but we were able to also offer that and go out to patients' homes, do the immunizations for children, refer people. People would call in, and for those who had emergencies, we had our database which had ambulance services, and we would always link them in case they needed to go to hospital, because we all know not every disease condition needs someone to go into a hospital, and some can actually be diagnosed remotely. And if there was need to have lab samples taken off, we would always send our team. We have a very huge team of laboratory technicians who are trained and can go to patients' home, pick off samples, and do that as well. So during the pandemic, we actually saw a lot of people embracing telehealth, and which they didn't before, and it was actually quite interesting. And we saw that there was actually something that a market for that here in Uganda. And in addition to that, we don't only have the voice, we also have SMS. So clients would also send SMS from as far as the north, the west, the east, and have doctors talk to them, give them the consultation, give them health advice, and help them throughout that process when they thought that they didn't have access to medical advice at that point. And since we are actually tech savvy and many people own mobile phones, SMS is something that we can tap into, and not only social media, because we also have that aspect. WhatsApp, Facebook, Twitter, people are able to get in touch with our doctors through all those platforms, but also the SMS platform has access to with our doctors. Ronnie, I don't know if you have any questions or anything that you would like me to add on to that.
Yes, of course. I'm very interested in what you have said. I like that there's been actually a shift or a gravitation of people towards telemedicine, because it's something that anyway COVID pushed us to learn how to take on and to take it by because we had no choice. But I'd like to inquire, can telemedicine be tailored to specific areas? If I wanted to focus, for instance, on the Luwero sub-area and Kiwoko hospitals area, how do we then merge telemedicine, for instance, with like the doctors at Kiwoko hospital? Or can any doctor really apply, or do they have to be specifically your kind of doctors? So that's just what I wanted to inquire, because I noticed that from a community perspective, people get more comfortable if I can talk to a doctor within my region. Is this something that telemedicine could do?
Yes, the beauty about this, Ronnie, is you just need one central point, and you can have doctors from everywhere. I'm going to give an example. At the Medical Concierge group, we also serve people in the Right North Lango catchment, the Right North Lango area, and we have Luo speaking doctors in-house. So there is also that trust that's because sometimes people call in and they're like, I want to speak to a doctor who understands my language, because that's the only way maybe they can express themselves. And we do have doctors from all over the country who are able to speak to these patients in their own mother tongue and create that kind of rapport. And the good thing with the telemedicine part is that the actual call center, if I may call it that, doesn't need to be within that particular area, because I take it Kiwoko serves a very huge area, so it can just be in a central place, but people all over that area are in position to access the doctor, as long as they have, let me say, the toll-free number or the short code that they can use to SMS. The hardest part is just setting up that one area So you don't need to have multiple centers in the different facilities, but you can have one access point with all these doctors there, and you tailor it to what your area needs, and you find out what your area needs and you make it fit its purpose for that particular area. So it's something that can be done for any area, any region within Kampala, I believe.
Okay, thank you very much, Dr. Pamela. I'm sure we're going to be reaching out to you significantly more to further this conversation.